Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hi there, it's my pleasure to be invited to share with you our experiences in interventional management of head and neck vascular malformations. My talk is mostly going to cover basic aspects of treating these lesions. I'm an associate consultant from the Department of Radiology from Hong Kong Children's Hospital. Currently, I'm also doing a pediatric IR fellowship at the Hospital for Sick Children in Toronto. So, a simple outline of my talk: I'm going to cover the what, the when, as well as the how, in the aspects of managing these vascular malformations in the head and neck region. One very important thing is the treatment strategy really depends on the type of vascular malformations. So, using the ISVA classification for vascular anomalies, which forms the basis of diagnosis for these wide range of vascular lesions. If we look into vascular malformations, there are these 4 groups. And if we then break it down to those that are associated with other anomalies, there are a lot of conditions that has genetic associations, as well as complex phenotypes. So my talk is not going to be covering on this, and we'll be focusing mostly on the simple vascular malformations, particularly lymphatic and venous malformations. Intracranial AVMs is a vast and complex topic requiring multidisciplinary management most of the time, so I'm not going to be covering this during my talk. So we'll focus on these 2 conditions. Now, accurate diagnosis is absolute key before we perform any intervention. Taking this 5-year-old girl with a painful swelling at the left floor of mouth as example, on clinical examination, there seems to be a firm swelling at the lateral aspect of the left floor of mouth that has been slowly growing. And you can appreciate on the T2 weighted sequence is of high signal on T2, and on post-contrast imaging, it avidly enhances. The surgeons proceeded with a biopsy showing possible inflammatory malvar fibroblastic tumor. However, on our MR report, it says the lesion is not suggestive of inflammatory malfibroblastic tumor, but more suggestive of hemangioma vascular malformation. Now, when there is an imaging clinical discordance, it's extremely important for the radiologist to examine the patient, him or herself. These lesions are mostly diagnosed on a clinical basis, and performing an ultrasound sometimes would also be extremely helpful in elucidating the vascular nature of these lesions. So when we performed a targeted ultrasound over the lesion, you can appreciate there is no compressible vascular spaces at all over the lesion, and on compression the lesion is totally incompressible. So we compare this with a patient with a true venous malformation. You can see that VMs are generally very compressible with hypoechoic spaces. None of these exist in our patient. So it's important to know that even on MR, these lesions may mimic each other. A thorough clinical examination and targeted ultrasound can solve most of the conundrum. This lesion turns out to be a superficial angiomyxoma, which is a benign lesion involving the skin and associated with the Carney complex. However, sclerotherapy or any interventional treatment is not indicated in this patient, and the best treatment would obviously be surgery. So when to treat these lesions? For venous malformation, they can cause pain, obviously disfigurement, and functional impairment as well as bleeding. Now, these lesions are not malignant. They usually won't kill the patient, but it doesn't mean that they don't negatively impact on their quality of life due to the disfigurement and the symptoms that it can cause. And for lymphatic malformation, again, they can cause functional symptoms as well as infection, hemorrhage, such as this ultrasound showing. When the lymphatic malformation gets infected or hemorrhagic, they can swell up and cause discomfort as well as disfigurement. So for venous and lymphatic malformation, the mainstay of treatment is sclerotherapy. Sclerotherapy is a word from Greek origin, sclero meaning hard or rock. So essentially you can gauge from the root of this word, it means that we're trying to make those vascular spaces harden up and stiffen up and obliterate them in the process. So I'll just show you an example of a 2-year-old girl with an orbital slow flow malformation. You can appreciate from the MR that it's causing proptosis of the eye and very close to the optic nerve as well. So when we inject sclerosing, in this case we injected bleomycin, the lesion will be filled with sclerosing, and usually we do it under image guidance. In this case, we use ultrasound to target our needle going to the lesion, and then we injected sclerosing diluted with contrast to show us where it's going. And once the sclerosing is in, it would trigger inflammatory reaction along the endothelial lining of the vascular malformation. And in fact, before the lesion gets better, it will swell up, it will get inflamed, and it would look very angry. And it's important to tell the parents that beforehand so that they have some sort of expectation management. Otherwise, it's extremely scary watching your child to come out of the procedural room and looking worse than it was before. It's important to remember the kids came here to get better and not worse, but they have to get worse before they get better. So it's important to warn the parents about that. And after the inflammatory reaction subsides, then there's a phase where the fibrotic tissue will come in and the lesion will scar down and shrink. So you can see that here at 28 months after treatment, the slow flow malformation has largely resolved with a very small residual component, and the eye is back to its normal position without any proptosis. Now, even I'm covering a very basic topic of sclerotherapy, dealing with sclerotherapy can be a very tortuous and complex process because even though they're the same disease, they have a lot of different manifestation, and there are just so many sclerosins on the market that you can use. So it's important to know the strength and the weaknesses of each, and there are just so much diverse mode of preparation and delivery as well. So if we look at this orbital slow flow malformation, this pharyngeal venous malformation, this venous malformation that is extremely closely located to the spinal canal, and this massive lymphatic malformation, it's important to have a good pre-procedural imaging to identify the potential at-risk target and non-target structures that you don't want to damage. For example, in the orbital slow flow malformation, it's important to outline the optic nerve, and it's also important to be aware that the optic nerve and, for example, the spinal cord can be injured or can be compressed during the inflammatory phase of sclerotherapy. It's important to counsel the parents on the prognosis as well as the post-sclerotherapy treatment course, especially if you are using sclerosis that causes a lot of inflammation. It's important to warn the parents beforehand. And having a good pre-op imaging and knowing all that potential at-risk structures, you can then choose the best sclerosant for the job. So this is basically all the sushi knives that's used by a Japanese chef, and there are many of them. Similar to sclerosins, it's important to know the features of each of sclerosin so you can use it well in in delivering your treatment. So some common sclerosing agents for slow flow malformation include antibiotics, in this case doxycycline, bleomycin, irritant sclerosant, most often absolute alcohol, or detergent sclerosant, which is commonly STS. It comes in 0.5%, 1%, and 3%, and in some locality you would have something like palidocanol. So for doxycycline, it's one of the most common and traditional agent used for macrocystic lymphatic malformation. The dosage is 10 milligram per mil usually in the mixture, and you have 100 milligrams in one vial. So usually we mix it in this dilution and administer to replace the amount of fluid that's aspirated from the cyst. It's important in neonate that we should not use more than 300 milligrams per session, as there is a risk of hypoglycemia as well as lactic acidosis. The worst case scenario is we can cause the patient going into acute renal failure. And there is also this questionable potential risk of teeth discoloration, initially discovered with oral treatment or intravenous treatment of tetracycline. The tetracycline will bind to the glycoprotein, leading to remineralization cycle, forming a black quinone, and this would deposit in the teeth. Now, it's important to note that on the literature, there has none case being reported of teeth discoloration secondary to sclerotherapy, but it's probably something you would bear in mind and speak to the parents before you bring the child for any treatment. And alcohol is one of the most well-known sclerosant, I'd say. Is one of the most potent sclerosant, which deserves a lot of respect. It's very irritating, and it causes immediate thrombosis and denudation of the endothelium, which can be damaging if it's extravasated. So commonly we use 0.5 to 1 mils per kilo per session, and depending how much opacity or strength of alcohol you want, we can dilute it with Omnipic. And this is what it looks like on venogram injection. So we would normally do a pre-injection venogram to delineate the outline of the venous malformation. And then we would use negative roadmap, meaning we would then inject the alcohol. You can see once we start injecting, the rest of the contrast in the dead space would firstly displace, and then the alcohol will come. The problem with absolute alcohol is the alcohol is non-radio opaque. So you're sort of relying on looking at the degree of displacement of the contrast to show you that how diffuse the alcohol has been. And it's important not to inject more than you have injected for the venogram, because with pressure, the alcohol can extravasate into different spaces and cause surrounding injury. So your goal is to fill up that venous malformation, but not overdoing it. Ethanol is one of the most versatile sclerosant available. So it can be used to treat venous malformation, macrocystic lymphatic malformation, as well as arteriovenous malformation. So this is a mandibular arteriovenous malformation, and alcohol, if applied carefully, can denude the nidus, but when applying the face and head and neck region, it's very important to understand the collaterals, the ECA-ICA connection, so that your alcohol does not go to any structures that is critical. And one thing with alcohol is it's extremely important not to mix it with Visipig. Now, Visipig is a commonly used isoosmolar agent in children, and it can cause this form of crystallization. So this is what happens in real life. You can see that crystal coating the syringe, and you certainly don't want that to be injected inside the patient. So just beware if you have this, if your practice is using Visipig commonly, you might want to take that off the shelf when you're doing sclerotherapy. For alcohol, ethanol can cause the most probably complication, the worst complication, and commonly ulceration and blister on the skin. And if we inject it close to a nerve, it can cause nerve injury. And systemically, especially if you are applying for arteriovenous malformation, the systemic dose of alcohol will be very high, and there is risk of triggering acute pulmonary hypertension as well as arrhythmia in the heart. So use alcohol with a lot of respect and don't overdose the patient. STS again is an extremely commonly used sclerosant, and there is just so many ways to mix it. The idea of mixing into a foam would increase the surface area in the patient, and you can use up to 20 ml of foam. So the detergent would react with the cell membrane, destroy the cell membrane, and cause immediate cellular lysis, such as this. Now, there is discussion on what to mix STS with. Some would propose mixing it with air, but not Lipardo, because Lipardo may reduce the lytic activity of detergent sclerosants. But there are other studies showing that Lipardo actually would stabilize the STF foam. So the verdict is still not out as to whether cell lysis or foam stability is more important in the use of sclerosing agent, and there is no clinical data up to date comparing the two. For STS, some common complications or expected side effects you might want to warn your patient or parents include hemoglobinuria. You will still get some bruising if applied sort of vehemently, and it's important not to inject STS vehemently, or you need to very carefully look for veno-arterial communication. Especially when you're injecting STS forcefully, it would travel through the thermoregulatory AV shunts and escape into the arterioles and cause extremely bad venous damage. Now, is STS safer than alcohol? This is again a matter of huge debate. We look at this paper from Great Ormond Street. It shows that the rate of neuropathy of STS is 1.1%, which is lower than that in alcohol. But then we look at sort of this image-guided sclerotherapy paper from BC Children's. It shows that in fact STS has lower efficacy rate but higher risk of complication. So the verdict is still not out as into which sclerosant has superiority over the other. It's important that you're using something that you're familiar with, and you're familiar with the injection speed as well as the side effect. Bleomycin is something really in fashion now. It's basically an antibiotic that causes a reduction in cellular proliferation. Its mechanism on venous or lymphatic malformation is not exactly well elucidated here, but there is probably some sort of fibrotic effect taking place. For bleomycin, we would propose a 1 to 3 milligram per mil, and we can use up to 15 milligram per session. It is important to observe the lifetime dose of bleomycin and warn the parents that it may affect future cancer treatment if the child grows old and live to an older age. For bleomycin, we commonly use interstitial administration, meaning that we're just injecting it into the interstitial space and allowing the bleomycin to diffuse and work, just as this case in the microcystic lymphatic malformation. So for bleomycin, its main use in microcystic lymphatic malformation, where it really helps reduce that bulk of the tissue that does not respond well to doxycycline. And also orbital slow film malformation, because bleomycin is one of the least irritating agent and would cause least damage to the surrounding structure. When using bleomycin, it's also important to note that it may cause these skin or contact hyperpigmentation. So it's important to warn the patient that, and it's also important to warn the anesthetist that you're going to use that, and you have to use a precaution, which I'll also show on the next slide. And for example, in this girl with 5-year-old with a cervical low flow malformation, after using 14 milligrams of bleomycin, she developed this interstitial pneumonitis that requires high dose steroid. So it's important, again, to take precaution, which I'll mention on the next slide. So we avoid any adhesive. We use wet gauze to cover the eye, and we use a gauze roll to tape the ET tube instead of the usual tape, so that we don't leave any adhesive markings on the face. We put the ECG leads under the axilla so that when they wear swimsuits, it's still sort of hidden, and it's not in an obvious spot. And we would use remove gently to remove all the adhesive associated. And it's important to communicate with the anesthetist. I'm not an anesthetist, but it's important for you to look at this figure, and you want to keep the FiO2 at 30 or less, so that it doesn't trigger the idiopathic bleomycin-induced interstitial pneumonitis. Now, how to deliver the payload? I mean, there's a large variety of way you can deliver it. For macrocystic lymphatic malformation, my go-to will be a 16-gauge angiocat, or if you can put a pigtail catheter in the lesion, that would be great. You can put the pigtail catheter in, drain the lesion, and then instill your sclerosant. And for VMs or LMs, you can also use a 22-gauge angiocatheter. Just make sure you use adhesive on the extension to make sure that stays in place. You can also use a butterfly needle. But again, the most important thing is you need the whole thing. You need the needles to stay in place during the sclerotherapy, especially between the venogram or the lymphogram and injection. You don't want the needle to come out so that you extravasate into the surrounding regions. Now, how to optimize sclerotherapy for the child. So obviously, the morphology of the venous malformation is important. If we look at the pre-classification, type 1, type 2, with no draining veins has probably the best outcome, because the sclerosant would stay inside the venous malformation and do its job. In 3 and 4, with dysplastic veins forming around the lesion, or the dysplastic vein is the lesion, sclerotherapy has worse efficacy because there is more escape of sclerosant. So if we look at this forehead venous malformation, on the venogram, you can see that it drains to the cavernous sinus. And this is something we want to avoid the sclerosant going into, because it would cause thrombosis and clots forming in the cavernous sinus. And on the AP, you can see that it drains through the superior ophthalmic vein bilaterally and going into the cavernous sinus. So what we can do is we can place clamps and compression around the venous malformation and cause the sclerosant to stay inside the venous malformation. And with the good outflow control, the sclerosant will usually stay in the venous malformation and not escape to areas where you don't want it to. And in this case of macrocystic lymphatic malformation, this is a 3.6 kilo patient delivered at 37 weeks by exit procedure. You can see how extensive that lymphatic malformation is. For this lymphatic malformation, the key is to treat the areas that is closest to the airway first, and drain those and sclerose those so that the airway can be restored and the child can be extubated as soon as possible. So, I mean, you probably need a lot of catheters to go into the different spaces depending on the intercommunication of the lymphatic malformations. And these lymphatic malformations often require a long treatment process. So, for example, in this case, we had to stage the procedure over 11 sclerotherapies over 1 month because we do not want to overdose in each sessions, and there is a dose limitation to each of the sclerosins. In these extensive lymphatic malformation, you can also mix different sclerosins. For this case, we use a mixture of doxycycline, alcohol, as well as bleomycin. So that would allow you to overcome a little bit on the dose limitation. And it's not just about sclerotherapy. For example, in this case, with a lymphatic macrocystic lymphatic malformation affecting the airway, we needed the ENT surgeon to help us with the exit procedure. And with the lymphatic fluid, we're able to do digital droplet DNA. And we were able to isolate the PIK3CA mutation from the fluid. And with this in mind, we can use medications such as sirolimus to reduce the cellular proliferation and lymphogenesis in these lesions to better control these lesions in addition to sclerotherapy. So all these complex looking venous and lymphatic malformations requires much more than just sclerotherapy. It requires a concerted effort of a whole village of IRs, surgeons, ENTs, clinical genetics, hematology, oncology, dermatology, orthopedics, and allied health to really optimize the treatment for these patients. You'd obviously be with an ophthalmologist when you're doing an orbital lymphatic malformation. You'd be with an ENT surgeon to look at your head and neck venous and lymphatic malformations. So with that, I'd like to thank you for your attention, and I'd like to thank my team, the team at Sick Kids, and all the peds IR I've met along the way in different parts of the world. That has taught me a lot in the management of vascular anomalies as well as vascular malformations. So I can be reached on this email, or you can connect with me on social media if you have any questions. So thank you very much.